Hi. Hi,
Hi,
everybody.
Chinna.
Can you hear me?
Yes, I can hear you. I hope others can hear us.
Yes. And maybe you can increase your volume.
Okay, my volume should increase. Let
No,
me
I'm
just
fine.
try.
I can hear you. If anybody else can't, so that's all I'm wondering. Okay.
Mine is full volume at the moment.
So is mine. Okay, fine. So good evening from India and other parts of the world. It's a different timing, and a very happy Navratra to you. And Navratri, as we all know, is worshipping of Ma Durga. Hello, worshipping of Ma Durga, and Durga is woman power, as we all know. So it's very important that all of us, not women, we must take care of ourselves and be empowered, not only physically, mentally, but in every possible way. And so I think today is a perfect day to talk about breast cancer awareness. And nobody better than my sister, who for me is the ultimate, as far as I'm concerned, for she's my go-to person for everything which is health related. Okay, and at the outset, first thing I would like to do is to thank my parents and our siblings and our entire family for being so supportive. My our mother, in spite of having gotten married at a very young age of 13, had the foresight. She was a feminist, so was my father, and wanted to educate all their children and empower them. And that is why we are where we are. And post marriage, my husband was equally supportive, and he's the one who had the foresight to get me into radiology. And my in-laws, my children, everybody has been very, very supportive. So a big thumbs up to all of them, and a thanks to all of them. Okay, and let me first introduce you all to Dr. Ambika Anand, a force to reckon with in the field of breast surgery. She, like me, is an alumnus of the prestigious Lady Harding Medical College, and this is now the only undergrad women's medical college in the world. Then she did her masters of surgery at Ram Manohar Lohia Hospital, which is also attached to Lady Harding. Then she taught at Lady Harding Maulana Azad Medical College, as well as Safdarjung Hospital. Then she did her FRCS from Edinburgh, and later another board certifying FRCS too. She is board certified in UK, trained in St. Bart's and Royal Marsden, and worked for 25 years in Boston and Lincolnshire in UK before relocating to Qatar in 2012. She's been doing a great job in Qatar, working at the Hamad Medical Corporation as a senior oncoplastic breast surgeon, which means that she is a breast surgeon, but she also does reconstruction and all along with that. So over to Ambika. Just if you want to address the viewers, you can do that. Otherwise, I can start with the questions.
No, thank you very much, Chinna. And it's an honor and a pleasure. And but more so, when you're hosting it, it makes me even much more honored to get that validation and recognition from my own dear sister. And do you remember last year we did something like this in Delhi together? And I think I said to you, our parents must be looking at from heaven, and I'm feeling so proud. And I think this is another very proud moment for all of our family members. And thank you
Absolutely.
very much for all the audience from all over the world, wherever you're joining. I hope this is a session that is useful to you, and let's get on with it.
Yeah, and before I start, I must tell you all that today, where I am, I owe a lot to my sister. Both of us are cancer survivors. She a breast cancer survivor, me a thyroid cancer survivor in 2014. And she's the one who flew down from Qatar to be with me on that particular day. I can never forget. And that's why I am alive here today. So I must definitely thank her for that. Okay. So first of all, why are we talking about breast cancer awareness? Can breast cancer be prevented?
So, before I talk about prevention of breast cancer, I just need to give you a little bit of information about what cancer in general is. Cancer in general is a disease of an aging cell. And cancer is not something that is just known to us in the recent last 50, 70, 100 years. It's always been there. You know, many but since we have conquered most of the epidemics and endemics, and it's far pandemics, barring the one that we have at the moment, I think people didn't live that long time ago. And therefore, many of those people didn't develop the disease to, live long enough to develop the disease and see the disease. As the humanity conquered most of the major illnesses, and we have come to a stage now more people have been living, and the average lifespan is much higher. You get to see it, and you get to see cancer in general more. But somebody will ask me a question: children do get cancer? Yes, they do get cancer. It's a different kind of cancer they get. It's a different etiology or causes for it. Now, breast cancer as such is not one single factor. It's not, you cannot pinpoint at one cause for it. It's multifactorial, and we still haven't found the root cause for it. We do know that majority of women who develop breast cancer, when I say majority, 95% of women who breast cancer who develop it, usually develop it beyond the age of 40 or 45, and it's called a sporadic cancer. It's a very small percentage, about 5% of women who develop it because they belong to a high-risk family. An example is Ashkenazi Jewish family, or some family in whom they carry an abnormal gene. It's called BRCA mutation. So generally speaking, if any family member has breast cancer, doesn't mean the rest of the members are high risk. You look at so many other factors. You look at the age at which they develop, how many other members of the family have, what other cancers have. More so particularly ovarian cancer and breast cancer families are considered high risk families. So I want to reassure the women, most of the women, that generally, breast cancer is not a very common condition. It's become, awareness has increased, and of course the incidence has increased, no doubt about it. So when I was a medical student, the incidence was different from when you were a medical student. When I was a medical student, we would probably see we were taught 1 in 12 women. And as time has gone by, and now when I teach my students, I usually say 1 in 9 women. If a room full of women were there, every 9th woman would develop breast cancer. And also remember, this is true incidence increase, and also awareness has increased, and also screening has increased. So screening, all of them pick up cases much before otherwise they would have normally developed the disease. So I want to reassure most women that women in general, in the general population risk as it is more common in older women. Younger women do get it. There may be a cause for it, there may not be a cause for it. But definitely, I live in a part of the world where I see more younger women develop breast cancer. I have no idea why. And it might be something to do with the genetic pool being smaller, or it might be to do with other factors. We don't know. We all talk about, could it be radiation? Could it be exposure to this food? Could it be exposure to hormones? Nobody can pinpoint a finger. Talking of hormones and things in older women, when women do develop menopause and have menopausal symptoms, many women are in hormone replacement therapy. And there has been some studies called the Million Women Study, which has shown that certain hormonal replacement therapy does increase the risk. That doesn't mean that women should not take hormonal replacement therapy. No, that's not what I'm saying. What I'm saying is you have to weigh the risk and balance. Some women cannot survive without having hormone replacement therapy because of so many other factors. It may be cardiac protection, bone protection, even a mood swing psychologically. So in those women, they take it. But there is a set time. The risk increases as time goes by. The longer they are on, the risk increases, and also the type of hormone replacement. Oral contraceptive pills, by definition, do not increase the risk as far as we know. There's not enough evidence to say at the moment, so that is fairly safe. Now, in terms of lifestyle risk, obesity definitely increases the risk. Obesity, smoking, alcohol, these are all high risk. And so I would say to any woman there, if you have to look after yourself, when you use the word preventable, I think lifestyle modification is very, very important. It's something one need to think about. a lot has been talked about dairy products, leave this and leave that. I'm not a great believer of that. There's no scientific evidence to say. Yeah, indirectly, a lot of dairy products are supposed to have disruptors, endocrine disruptors. I'm not sure whether you should go all out and say no to it. I don't believe in it, and I don't think there's enough evidence to say. There are a lot of books written on it, but what happened there?
I think
I
your
think you'll have
net
to keep pressing the
is
screen.
unstable.
So,
Yeah.
yeah. So I don't think it was the net. I think sometimes it just, if you're not, if I don't keep at it, just will go to sleep.
Yeah, it goes in that locked mode. Yeah. So
Yeah.
that's why I keep it
So
unlocked.
so
Yeah. Right. Yeah.
I think you have to sort of, lots of books are written, but you shouldn't go by all the literature that is written. Sensible eating, lifestyle modification, weight control, alcohol, smoking has to be avoided, and I think those are the things that I would say in terms of prevention. So, but remember, by virtue of us being women, by virtue of women over the age of 40 or 45, we are already at a risk. Okay, but doesn't mean that only women develop breast cancer. Men also
Yeah.
develop breast
That
cancer.
is.
If I were to see 100 women with breast cancer, 1% of men would have breast cancer. So it's not just because of anything we are doing that is happening, anything we are not doing that is happening. It's simply that it's one of those things that has happened, and it takes less than this amount of time for a normal cell to become a rogue cell, and that's what happened. Does that answer your question, Chinna?
Yes, it does. Now, I
Yeah.
would like to ask you why Pink October? Of course, having said that, I would say that it's not just October. I have been reiterating in my posts also. It's not just Pink October or any one particular day. We have to be breast aware always, not just in one particular month or one particular day. But why Pink October? And like everybody can see, I am wearing this pink bow, and this bracelet with this pink bow, which Ambika, my sister, only gave it to me. And this is a sign of, it's a symbol for breast cancer awareness. She also is wearing. So I would like her to elaborate on what is pink bow and why Pink October.
So yeah, I don't know why October in the sense. If you look at the cancer calendar as such, each month is given for each. So you have prostate cancer for November, and I think breast is in October. So each month has been given so that people talk about it.
Yeah.
Now, pink ribbon was never the original symbol for breast cancer. It has gone through a lot of history, and it was originally a lady who was a grandmother, mother, and actually sister of and daughter of breast cancer, patients. And so she's actually started distributing peach ribbon, and which she made only from her, dining room. And it was primarily to raise awareness because the funding for breast cancer was not that much. So she just started raising awareness. And this was in the late 90s or the early 90s. At the same time, I think the Self magazine editor wanted to do something about breast cancer awareness, and also Evelyn Lauder, the Estee Lauder family person, she's a breast cancer survivor. I don't know whether she's alive now or not. So she had wanted to do, and while Liz Smith, who's a writer, was writing about the peach ribbon, she came across and she told the the Estee Lauder family, you guys want to raise awareness. There's already a lady who's doing a peach ribbon, and I think they had conversation which probably didn't work very well. So
Yeah.
the cosmetic company decided to launch, because peach was the color that lady and there would be legal issues. So they decided to launch pink. Now, pink, why pink? Pink, I mean, I know present day politically it cannot be correct that you should do a gender conformist with a color, but pink is a color which is supposed to be tranquil, peaceful, self calming, and it was called quintessentially female color. So it was chosen, and there's one particular pink. It's not any pink. It's 150 pink, which is the light baby pink color that was used. Why ribbon? I think the whole ribbon campaign happened after the yellow ribbon was tied after the
Yeah.
whole Way of Tree, when when the hostages were coming back from Iran. And then AIDS awareness happened with the red ribbon.
The red
So I
ribbon.
think, and then it became just a ribbon, and then it was a pink ribbon. And now millions and millions of pink ribbon have been. So I think before you think pink, you must always think as to why this ribbon started. And I think we should pay tribute to Charlotte Haley for having even started that conversation before anybody
True.
else did. That is what is important.
Yeah.
Yeah.
Just by the way, I would like to remind everybody there's a very well known song about yellow ribbon, tie a yellow ribbon around the old oak tree by Perry Como, because that's how the reference is, Okay. Now, she's already talked about causes and risk factors, and there is a family history, like she just said about this lady who started the peach ribbon because there was family history. Now, how important is family history? I would like you to elaborate on that.
So whenever a patient comes to me and says, one of the family member diagnosed, they usually panic. And so you just have to take so many other factors into consideration. You need to find out what is the degree of relative. Is it the first degree, second degree, third degree? Is it age of the person? If the person young or old, generally speaking, older, elderly population, in the beyond 60, breast cancer, or even beyond any other age group, beyond 45 is not considered high risk. But there are now newer factors have been introduced, which is looking at more like a receptor status. So any woman who has a breast cancer, which is triple negative below the age of 60, she's considered high risk, and she will be considered high risk for genetic testing. Her family is not considered high risk, but she is considered high risk and therefore genetic tested. Now, so you need to take a very detailed family tree history. You need to say maternal, paternal, who are the members who are involved, age of the members who are involved, what is the family history? Is it breast cancer, ovarian cancer, thyroid cancer, colonic cancer? What are the cancers? So, and then the whole cancer from the paternal and maternal history does not add up unless they were married, cousins were married, between the families. Whichever is the highest risk, whichever side of the paternal or the maternal lineage will be considered the risk that one would take, whichever is higher. And then any alive member who's got breast cancer is tested first, provided they consent for testing. Remember, the genetic testing is not like it's not like a regular blood test. You have to counsel people, because you need to know what they would want to do, what they have to do, or what they not must. What are the implications? No point in saying go and have a genetic test, because if you have a genetic test, you should be able to deal with the consequences of the genetic test if it is positive. What you don't want is you have the genetic test, somebody does a genetic, and it is positive, and it's like a Damocles sword hanging over your head.
Exactly.
So it's a major responsibility. I know there have been quite irresponsible is the word I would say. I would again say it's irresponsible genetic testing that has been offered in certain parts of the world, where people have said, oh, we can just do a genetic testing. And you see, there's nothing like a random genetic testing. There's no test like that. You have to identify the abnormal gene in that family member who has the disease, and then if the gene is identified, then only the other members of the family will be tested. Okay. So random testing, one blood test, one swab from the saliva, all that being promoted and touted, it's not the way things are done. Okay. Does it answer your question?
Yes, it does. Let's now talk about breast self-examination. So much has been talked about earlier, and now they say that breast self-examination is really not advocated. And also they have come out with devices like a torch, which is very misleading. I don't even know if it's FDA approved. And then there are all kinds of testings like thermograph and all. So I'd just like you to talk about whether breast self-examination is necessary, or just being aware of your breast and any new change in it is what is more important.
So lots of points here. Number one, let me go to the self-examination bit. Now, self-examination was something which was promoted quite a lot, and I know there is somebody in the Instagram have also said about self-examination. Remember, any woman who examines her breast will find the breast always lumpy. She will find always lumpy, and it increases the anxiety, and it will just create, if you have been taught properly, then you should do self-examination. Otherwise, if you just do it and you'll find lumpy, you would create, problem. What you need to know is, you
Panic.
need to know breast, what your breast is like. If there is any new change, you need to actually be aware of it and escalate it to the physicians that or anybody that you need to see. Now, in relation to, so I'm basically saying breast awareness is important. And be aware of your breast. And if there is any new symptom, please escalate it. Please go and see a surgeon. I think lots of gynecologists are doing breast services because women feel comfortable with them. I think, remember, breast cancer, breast surgery, it comes from a general surgery background. And I think people should go and see surgical opinion rather than gynecological opinion. Then comes to using some of these devices that you talked about. I would like to say, and you use the word FDA approved. FDA can approve anything. You pay them and they will approve anything. Okay, so I would not even go by the word FDA approval is the stamp for anything. Torch, thermography, or any of those things are to be mentioned, to be condemned. Full stop. No, I will not even go even more second beyond it. The other thing I want to say about self-examination is self-examination does not save lives. Self-examination is not a substitute to breast screening when the screening is offered to you at that age, whether it's 40 in UK, in USA, 45 in UK, 44 in UK, 45 in Qatar. Take it. Because self-examine, I don't have any lumps, so I don't have to do examination. Go. You're in that age group. Beyond that age, you must go screen. Self-examination does not save lives. I want them to know. Okay?
Yes. Yes. So what are the symptoms that...
I wanted to add something about bras as well. A lot of people
Yeah.
think, if I wear a black bra, it attracts radiation, therefore chance of breast cancer. Or if I wear an underwire bra, it will give me problems. So I want to be honest with you. I think 90% of women or 99% of women don't even wear the right size of bra. I wish I could have invented a bra that and I would have, not necessarily made millions just for the sake of money, but actually good service to women. A bra has to be one which will give you a good support. Support thereby meaning not pushing the bra, not pushing the breast and making a great cleavage. That is not what we are looking at. Really giving you support so that the breast doesn't keep moving. And if it moves, it pains. And one of the reasons why you need a support bra is primarily to give that less movement and therefore less pain. Normal women, 95% of women will have breast pain during their entire reproductive phase. It is not cancer. Breast pain is not synonymous with cancer. Very small percentage of women who have breast cancer present with breast pain. Very, very small. And that too in older women, not in younger women. But it is one of the most annoying symptoms. And my practice majority are breast pain patients, breast pain young women. And it's very important to reassure. And I often see them with underwire bra, and I actually tell them, just wear it and show me what happens. I don't want to be graphic, but when the underwire you wear, at the end of the day, in the evening, go and have a look at yourself. The wire will have digged into your breast on the side.
Absolutely.
And you have a mark of the wire. And that itself gives you pain. So what you need to do, I don't want you to go and buy an expensive sports bra and a support bra. Nice, good cotton bra, and you have the strap really tight is good enough to give you good support. And that will give you a lot of pain relief, okay? And even at night, a lot of people say, when I have breast pain, I don't want to wear a bra. Actually, it's a myth. And it's actually contradictory. If you actually support the breast quite a bit, you will have less pain. It's like any kind of bruise anywhere in the body. You support it, you bandage it, it gives you less pain. So similarly, wear a good, well-fitting bra. Ill-fitting bras actually they don't cause cancer, but they give you pain and discomfort and bruise and various things. Yeah.
But if you don't wear a bra at night, there's no problem. No, if you are uncomfortable, you don't want to wear one at night.
That's nothing wrong if you don't want to wear it. But women who have breast pain, they will say, I don't want to. I tell them, wear a tight-fitting T-shirt. Tight-fitting T-shirt, so the breast doesn't move or sag around.
Yeah, right. Okay. What are the symptoms that one should look for? What are with which the patient usually presents?
So I don't want to talk to you about breast cancer as such. I want to just talk to you about how women present with general breast complaints. Our breast complaints are generally breast pain, breast lump, nipple discharge, uh, and these are common symptoms women present with. So young women will have breast pain. Could be cyclical, could be because of periods and physiological. Okay, and if it is more annoying, there are, and one of the things I always say is note the kind of pain that you have. Find out whether the pain is got a pattern. Find out the days that you have. Our brain is very funny. It only remember bad days. It doesn't remember good
Yeah.
days. When you put it on the calendar, you'll realize that you only have pain for a few days in a month. Okay, and it might be actually related to it. And remember, hormonal levels are not measured amount. Sometimes you have high, sometimes you have low. So these are things that you need to be understand that, and it's one of the most annoying symptoms. And there are a lot of people talked about vitamin E, gamma linic acid. I think none of them really actually have major. They are quite experimental or very much, if you want to try because they're not without side effects. I think one of the things they need to be reassured is any woman who has a breast pain must seek help, must get the imaging done, exclude any other problem, and then get reassured and then see. Some women have very severe pain for which they might have to be given hormonal tablets to suppress their functions, and that might happen. And regarding discharge, normal discharge in the breast is greenish, yellowish, milk when women are lactating. Some women even discharge milk even when they're not lactating. Not all women who don't are not lactating produce milk have prolactinemia, which is high levels of prolactin. You can have it's called idiopathic, and don't squeeze your nipple or your breast to express that discharge, because if you do that, you'll end up damaging the ducts and you'll end up having bloody discharge, and bloody discharge is a worrying symptom. Now coming to the worrying symptom, when I'm staying with the discharge, nipple bloody discharge, which is spontaneous, is a worrying symptom. They need to seek help. Clear discharge, water clear discharge. I'm not talking milky. I'm talking water clear discharge. Could be benign, could be a papilloma, a small little grape-like tumor, which is benign, but you need to seek help. We need to get investigated. Lump in the breast, majority of young women have what is called a fibroadenoma or breast cyst. But please seek help and let the clinician do a clinical examination, what is called triple assessment, clinical examination, imaging, which may be ultrasound for younger women, mammogram when you are beyond 40. Not everybody need to have a MRI, and if it's a palpable lump, they must have biopsy, not FNAC.
Yes.
Biopsy to say it is benign, which is fibroadenoma, and they can be reassured. If it is below 3 centimeters, you don't need to remove it. Fibroadenomas don't become malignant. Why don't I say FNAC? FNAC used to be done. FNAC does not give you all the information that you need. When women have breast cysts, which is quite common, breast cysts are like little balloons which are filled with fluid, and that could be because every month the breast is being prepared to get pregnant, and when the pregnancy doesn't happen, evolution takes place. The breast involutes and the glands and everything become smaller, and the liquefaction of the tissue happens, and that is when these little areas become filled like balloon filled with water, and these are called cysts. And cysts by themselves are not are annoying because they're lumps. They're painful because they become bigger and they burst, and then it becomes painful because it stimulates the pain fibers. But neither fibroadenomas nor cysts are precursors for breast cancer. Just because somebody has these things doesn't mean they will go on to develop breast cancer. No. And no surgery is needed for cyst if it's really big enough, unless the cyst has a papilloma or some growth inside it. You don't need to remove those. Fibroadenomas, if they are not beyond 3 centimeters, you're proven. Tissue biopsy has been done, it's been proven, you can reassure. Unless it is really massive, if it is beyond 3 centimeters, you suggest removal. Or when the diagnosis is in doubt, you will remove it, provided you get all the imaging and results, biopsies results done. Now, why did you, I know you nodded your head about FNAC. FNAC was a tool which was quite helpful. But now the management of breast cancer has become far, far specific, very individualized. Just knowing by FNAC it is cancer or not cancer does not help anybody. I know there are some pathologists, some cytologists in India who claim they can do FNAC. In the FNAC, they can tell you whether it's invasive cancer, it's non-invasive cancer, receptor status. I haven't been lucky to find that cytologist in my life as yet. So I would say I don't know. I wouldn't do cytology. I would do histology, confirm. If it is benign, if it is reassurable, reassure them, discharge them. They know. Occasionally, what I do is fibroadenomas. I will follow up in 6 months' time to see the trend. Now, fibroadenomas, 30% will disappear, 30% will increase in size, 30% will remain the same. I don't know which 30% the patients are. I might do one other one and see the trend and then reassure them about it. Yeah. Yeah.
Why I was nodding my head was because in my course of work, what I had found is many a times the moment a patient would present with a lump, the first thing the clinician would do is to put in a needle, and after that, imaging would become so difficult because sometimes they would really in the process of doing an FNAC, and that to a blind one, not with the support of an ultrasound where you can see where you are going, they would mutilate the whole thing, and after that imaging would obviously give not the correct result at all. So that is why I was nodding, because you were hitting your head against the wall trying to tell them not to do FNACs. And
So
also another thing that people feel is that there will be seeding of the breast cancer if they do a needle biopsy or an FNAC. This is another thing which I would like you to reassure everybody, that doing biopsy does not mean that you are spreading the cancer in any
So
way.
one of the things is you hit the nail on the head. Is like when you find a lump, the lump might have what we call it variable consistency. At some place it may be liquid, some place it may be hard, even in benign ones. So
Yeah.
when you do blindly, you might not hit the right spot. Whereas if you do image guided, and I said about triple assessment, you do a clinical examination, you do imaging, and then you do an image guided biopsy. And then when you do an image guided biopsy, you're targeting the right area to get the right tissue for biopsy. Now, if you do core biopsy or an FNAC and do an imaging, for example, there'll be a lot of hematoma, there's a lot of bleeding, and that will give you erroneous imaging results, and therefore one would be misled.
Yes.
Now, the other thing about seeding, it's a myth. I've been in this specialty for I don't know how many decades now. I have not seen a single seeding because either because of the needle track or because if I touch the cancer, it will spread everywhere. That's a myth. And the third thing that a lot of people do, I'm sorry for saying, my surgical friends do, is a patient comes to you, let me take the lump out. You know what?
Yeah.
Be forewarned with the information given to you. Please have all the information, because you know what? The first surgery may be the only surgery the patient needs. The first surgery may be the best surgery for the patient, i.e., if it is cancer, and if you know on ultrasound and biopsy, then this patient will be discussed, and if this patient needs surgery, upfront surgery, then you will have to do a surgery with a big wide margin. You'll have to orientate the specimen. You may have to take the lymph node for a sentinel lymph node biopsy to get the information. Whereas if you do a lumpectomy and send, you'll actually cut through the cancer. So that is, you've actually jeopardized the patient. The patient might have to have a second surgery, might have to have a third surgery. So please, I'm saying this to all my, if any surgical colleagues, anybody watching, or even I'm actually arming the women out there. Ask the question, why do I need the surgery? Ask the question, do you not need to have more information? You in your practice, remember when I was in India, you would call me and say, Sivi, I have a patient here who just had lumpectomy only 10 days ago without any imaging done before. That is criminal. That is criminal. That's criminal. It should never be done. Never be done. Okay?
Yeah. And now let's talk about the modalities that we use for diagnosis as well as screening. So because so many people, like you said, that they're worried about radiation due to mammography and will avoid mammography and say, no, I only want an ultrasound. The problem is when the patients decide, and many times the doctors who are referring them are also ill-informed. Oh, no, 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 don't go for an ultrasound, no, don't go for a mammography. It's best to do only MRI, not realizing that if there are calcifications, you're going to miss them. And that might be the only way to diagnose that particular cancer. So please
So,
do touch upon that as well. So.
one of the things is what are the modalities of investigation, which all depends upon so many factors. And you also talked about screening and, when you say modalities of investigation, that will be for symptomatic patients. Screening is for women who don't have any
Well,
symptoms.
no,
Now,
symptoms,
for
right?
the women who are symptomatic, if they are below 40, then we start off with a simple as an ultrasound. Don't go jump into mammogram. An ultrasound shows something abnormal, and if you have, in those situations, you'll have to do a mammogram and then even an MRI, because mammogram dense breast you may not be able to see. Whereas a woman who's 40 start off with a mammogram, ultrasound is often added to it, because you need to look at the lesion. You might have to do ultrasound guided biopsy and insertion of a clip, and you'll have to do biopsy or under the arm to look at the lymph node. MRI is not MRI is not a substitute to any histological diagnosis. Okay? MRI aids, MRI helps, but MRI is not a substitute. Then talking about the radiation, the amount of radiation exposure that one has with mammogram is less than what we get when we walk out on the street. Okay, so I think the amount of radiation that we get outside is probably much more cumulative than one mammogram when done. Okay. And the other thing is women, I know a lot of private practitioners in India get women below 30 mammograms. I've seen
Yes.
mammograms coming, and that's criminal. You don't need mammogram for them. You start off with ultrasound. And PET CT is not a substitute either. PET CT and CT scans are not substitute to breast imaging. They do not have the same resolution, and they do not show the same thing that what we want as breast surgeons or breast radiologists. Now, screening women. Screening technically is used for women or general human beings who don't have any symptoms. This is to screen for a disease or a prevalence of a disease. So here we are talking about screening for breast cancer in women. Okay, done at different ages. In US they do every year 40. In India I don't know what they do, but in UK they do 45, 44, and in Qatar again 44, 45 every 3 years. Ideally speaking, it should be every 2 years, but when you have a national screening program, which is not suitable in India, it's a lot of money. And there are people who now are against screening, not because of the radiation. They just think that we are only bringing diagnosis of the disease forward. Some of the disease that we diagnose in screening are very small and in non-invasive or pre-invasive, and you probably are actually putting the patient through too much anxiety. A lot of trials are going on at the moment, but you cannot say that screening does not help. Screening does help. Now, screening is mammogram. There's no MRI screening. MRI screening is only done for high-risk women who are below 35 years of age, who have come from a high-risk family, and those are the women who are screened by MRI. Older women are not routinely screened by MRI. And some countries they do two views, some countries they do single view. It all depends upon your own, policies and what screening policies you have. And the amount of radiation exposure that you have is, as I said to you, if I were to travel from here to Australia, I'll probably get much more irradiated than the amount of mammogram that I will have if I have to have mammogram every 2 years or every 3 years. Does it answer your question?
Yes, it does. Now, I would like you to discuss very broadly what are the what are the kinds of treatment that are available, and also that it need not always be mastectomy for every individual is something that I would like you to tell everybody.
So one of the things about breast cancer is individualized treatment. You will have outside in my waiting area, there may be patients who talk among themselves. Somebody would have mastectomy. Doesn't mean they have much aggressive disease. The nature of the disease may be different. They may have disease in different parts of the breast, like more than one quadrant, as we call it, more than one sector, as we would call it. Whereas somebody else may have a big tumor in one part of the breast, and we might have to give that person a chemotherapy before. And another person may have a very small tumor, but lymph nodes are all positive. So each individual will have a different treatment. Okay. General treatment is local treatment, systemic treatment. Local treatment is surgery, which could be lumpectomy in some people. In some people, it could be mastectomy. Just because somebody has mastectomy doesn't mean they have a much aggressive disease. No. It doesn't mean that anybody who has breast cancer has to have a mastectomy. Even that is not needed. Because there's many years ago that was the belief in the 60s, but then when radiation came, treatment came, women were being unnecessarily mastectomized as compared to women with the same disease if they could have lumpectomy and radiotherapy. So lumpectomy and radiotherapy give the same result after mastectomy. And sometimes women think, oh, I don't want to have radiation, so I'll have a mastectomy. They will be in for surprise. Even after mastectomy, sometimes they have to have radiotherapy. So no one treatment fits all. Not everybody has to have chemotherapy. Sometimes we give chemotherapy, the number of drugs and combination of drugs. How many is not fixed, is very individual. And there are a good proportion of patients who might have large tumors in whom you might give them chemotherapy before to shrink the tumor and then do inappropriate surgery. And most of these cancers, you do need to have some information on the lymph node. So you will take either lymph node sampling or take out the lymph node depending upon the status of the lymph. Now, hormonal treatment again depends upon the status of the receptors. Receptors are like proteins which are exhibited on outside the top of the cell. And depending upon what they are, they may be hormone positive, hormone negative. And there's another drug that we give, which is called a target therapy, Herceptin. Again, is another form of receptor. Herceptin is a double-edged sword in the sense when women find that some of the patients find that they have Herceptin positive tumors. The tumors are supposed to be aggressive, but if these patients have Herceptin positive tumors, HER2 positive tumors, when you give them Herceptin, that actually changes their lifespan or survival benefit because Herceptin gives excellent survival benefit. You know, just to give you a little indication about maybe 30 years ago, 35 years ago, patients who had developed breast cancer and had liver spots, bony spots, brain spots, we would just say, okay, make them comfortable. Now those patients, because oncologists have done such a marvelous job, the number of drugs, the first line, second line, third line, managing the side effects have come up so wonderfully that women are living much longer. Much longer with better quality life. Okay. So I have a personal friend of mine whose mother, as we literally speak at this time of the year, 5 years ago, had extensive bony mets and she was HER2 positive tumor, and she has been doing really well. She's on treatment 5 years. She's seen 3 extra grandchildren, and she's really doing well. So I think credit to the oncologists. They've done a marvelous job. A lot of people have bad publicity about chemotherapy. Chemotherapy is not easy. I agree. Chemotherapy has side effects. But you know what? It is a necessary poison. If you have to have it, it gives you 1% benefit, take it, I would say to people. And one of the things people worry about, the most important thing worry about is hair loss. Hair loss is temporary. It will come back. Okay, it will come back. You just have to manage it. That is only a small price to pay. Very small price.
Okay. And now they have cool cap also. If you just touch upon that also for the knowledge of the viewers.
Cool cap has been there for a long, long time. It came, it went out, came and went out of fashion. It's been there a long time. It's not an easy option. I would say the reason is that cool cap is like having a big ice cold freezer on your head. And it has some advantages that, because when somebody puts a cool cap, the chemotherapy drugs don't reach the skin of the head, and therefore the hair loss doesn't happen. But there has been some studies to show that the skin deposit tumors are increased when you use cool caps because the chemotherapy doesn't reach there. So it has to be very much evaluated, discussed with the clinician, with the therapist who provide that service. Not everybody can use it. No.
There is a question for you. Please talk a little about triple negative breast cancers.
Triple negative breast cancers are nasty tumors. They are not, one of the things is they are nasty, but there's a good thing to it. They respond very well to chemotherapy, extremely well to chemotherapy. Okay, so they may be aggressive on one hand. Aggressive, sometimes the more aggressive the tumor, they respond very well to chemotherapy. So the much newer medications that are coming up, I'm not an oncologist, so it will be wrong of me to even name a medication because I'm not that well versed with all those. So triple negative tumors are, there's lot of new medications are there, and then they give first line, second line, third line, and a lot of trials going on. So there is silver lining to the dark cloud there. Yeah.
Okay. And what are the chances of recurrence? Nobody can say who will get a
So,
recurrence.
so
And
this cancer in general, but this cancer particularly, you cannot use the word cure for an invasive cancer even after 20 years. The more number of years one has without the disease coming back, it's a bonus.
yeah.
The only thing I would say is the recurrence. How do I tell my patients? Recurrence is 1% per year. Whether you do mastectomy or you do lumpectomy or radiotherapy. Whatever treatment one has, like hormonal treatment, they're all called insurance policies. So you can you have them to prevent the disease from coming back. There's no guarantee. It's not a failure on the part of the surgeon. It is not the failure of the treating physician. It's what the tumor does in that particular person's body, how it's going to behave. There's no way. I mean, you have to do your bit. The clinicians have to do their bit, and then rest we have to leave it to some other forces to look after.
True, true.
Yeah.
What are the chances of pregnancy following breast cancer? I also had a patient who was only 26 years old and was discovered to be having a lump during her honeymoon. But after 7 years, she did conceive, and now she has a child. But how safe is it? And is there a chance of the malignancy resurfacing during pregnancy because of the hormonal changes?
So the thing is that what happens is, before, long time ago, when women used to get pregnant, young women, and we used to say, "Oh, can never get pregnant," and which was quite kind of harsh. So what do I tell my patients when they are young? Because very often many of these women would be on tamoxifen, which is the anti-estrogen tablet, and some of them would also be, in addition, might be on what we call Zoladex, which suppresses ovarian function. So I would usually say, if they are in their 20s or 30s, which is not that often that you get to see that patient, but you do see young patients, then I would say finish your treatment for 5 years. Okay, and then you can. And also, if they can preserve the ovaries before, or ovaries before they get chemotherapy, ovarian preservation is very important. Because you don't know what will happen to the ovaries. With one of the ways chemotherapy works is through the ovaries. It puts the ovaries to sleep. So I would say any young woman who's in a reproductive age wants to have family, if she's going to have chemotherapy, she should discuss ovarian preservation to begin with. And then, if a ballpark figure nowadays people quote is, if a woman wants to have a child after being diagnosed, usually leave them for 2 years or so. And generally, I would generally say, if they're young, I would say 5 years. And if they are older, like 37, 38, then I would say 5 years for them is too long, because they'll become 43, 44, then they can go to menopause. So I would say 2 years. Resurfacing during pregnancy is a draw of the lot. Nobody can tell you. It is the same recurrence rate I will quote. Yes, maybe because, for all they might have had a hormone negative tumor, receptor negative tumor. Or, that might not matter, but that is the chance that one has to take.
And what is the role of alternate medicine? Because I remember, of course, seeing many people going in for homeopathy with a florid breast malignancy, and of course, going downhill. But there is a role for it in palliation post, the main treatment like surgery or chemotherapy. What do you say about that? Is there a therapy, and also a psychotherapy also is a very important aspect of
So
any
I want
malignancy?
I don't want you to misunderstand me here. I don't want you to use the word alternative. It is not an alternative. It's complementary. Okay?
Hmm.
It is not alternative to allopathic medicine or the standard treatment that you have. Complementary medicine, which could be homeopathy, Ayurvedic, naturopathy, aromatherapy, reflexology, cupping therapy, whatever it is, they help control, sometimes handle chemotherapy related side effects. But what I always say to my patients is do not have any antioxidant treatment while having chemotherapy, because you want the cells to be actively working even if the cells are not there in your body. They may be hiding somewhere. If you give antioxidants, cells goes to sleep. So therefore the chemotherapy does not work. So do not take any antioxidants while having chemotherapy. Number one. Okay. Number two, they can have acupuncture, acupressure, all those things they can have. And remember, the complementary medicine is more to boost your immunity. It may be
Yeah.
for after you've finished your treatment. Okay. Absolutely, it is not an alternative treatment, and there's no treatment in homeopathy. There's no treatment in Ayurvedic.
In Ayurveda.
I can only talk to you about my line because I'm not being arrogant. It is evidence based. There is no evidence. I cannot. Nobody has been able to show me the evidence. So I would not say
Yeah.
these.
No, no.
Like I had a young woman who had come, who was the wife of a professor this many years ago in India, and he went and he said when the lump was actually fungating, the homeopathy actually said, "Oh, that's very good because the tumor is coming out." I have never ever seen
Yeah.
what she was stage 1 became stage 4 within a matter of few months, and she died within a
Yes.
year. So I want to tell all those people out there, I had a relative in my in-laws, and this girl had kept, and she's a very intelligent girl. I have to say hats off to the Ayurvedic hospital in Delhi. She went to them, and they said, you know what? This is You have to be treated by allopathy. When you have chemotherapy, when you have side effects, then you come to us, we'll help you. That's all they told her. And I thought that was very, very
Yeah.
good that they said that to her. Yeah.
No, no. The reason why I raised this was because I know that people do this, and the idea was to drive home the point that please do not do this kind of foolishness.
No, no,
And
there's no
last but
alternative.
not the,
It's not alternative. It is not alternative treatment.
yeah,
It
it's
is
not alternative. Yeah.
complementary medicine, complementary medicine. It's not alternative. I want that to be hammered. Yeah.
And lastly, I would like you to share your journey as a breast cancer survivor. What has been your experience? And if you could just
So
talk about it, because it'll give strength to so many people here.
I'm 21 years now since I was diagnosed, almost 21 years and 2 months now, nearly. And it doesn't get easy. It doesn't get easy. But the thing is, you have to understand that it's not because anything I did wrong or I didn't do. I'm a vegetarian. I breastfed my children. I did everything within the only thing that I had, which I think is never talked about so much, is the amount of stress. Stress does something
Yes,
to our body, Stress does something to our immunity. It probably decreases our
true.
immunity. And therefore the cell might become a rogue cell. I have no idea. But I think that's the only thing I can talk about. And here I am. I did whatever I had to. You just have to be brave. You have to be strong. Sometimes, in spite of everything, patients don't do well. There's nothing any one of us can do about it. It's not because they didn't do anything right. It just simply, and I think seeking help immediately and being compliant with your treatment, being compliant with your physician's recommendations is very, very important. You do your best, the physician does his best, rest you have to leave it to God. That's all you can do. There's nothing more you can do. Somebody sent a message, and I don't know whether they sent a message in my WhatsApp or in here. Something about aesthetics. I don't know. Did you see that message, Chinna?
No,
Somebody, let me just, can I, if I open, if I go to WhatsApp, this will get
no, I think you
disconnected.
will it'll get disconnected. So, uh,
Because somebody said something about aesthetics. I don't know what aesthetic means. I mean, if people are talking about whether anybody should have cosmetic surgery and if whether cosmetic surgery by implant by itself increases the risk of breast cancer, there has been some conversation about breast implant associated lymphomas. Okay, but that is a very small and that's only particular type of implants. It's not that common. And the other thing is cosmetic surgery by itself is not dangerous in the sense if somebody wants to have it, want the breast to be augmented, all the implants are safe. And now modern day implants, you can even have saline implant, and it can be forever. It doesn't have to be changed every 10 years. No, there's no more need for changing it. Does that answer your
Okay.
question?
Mhm.
Yeah.
Yes, it does. And I would like to thank you. And before that, I would just like to ask you, do you think willpower plays a role in combating, in fighting breast cancer, I would say, not
So I
preventing
wouldn't
it or
I
once you get
wouldn't
it, yeah, how to fight.
I wouldn't use the word fighting, and I wouldn't use the word combating. I wouldn't make it look like a war, okay? I would say to people out there, willpower does things, it's biofeedback. Okay. What have you got to lose? You've got nothing to lose there. You have either you sit there and cry, or you sit there and say, I'm not gonna let it be me. You can only do that bit. And I'm sure all this biofeedback does something to one's immunity. I don't know. It must do something to one's immunity. And therefore, when we are faced with that kind of a situation, we have to find an inner strength in ourselves. But lifestyle modification is the most important thing for whether for prevention or for survivors. I always say to survivors, because I've got a huge following now, survivors all over the world, and particularly in Doha, the other clinicians that I work with, we all have. And one of the things about survivorship is it's once you're talking about sexual health, your emotional health, and your weight is important, your lifestyle modification is very important.
True.
I think that is one of the key things that one has to think about. Yeah.
I can't thank you enough. And I'd been wanting to do it since last year. And I'm very, very glad that on the first day of Navratri, it is the blessing that I have received that I have been able to do it. And for the benefit of so many, because this is a subject which is very, very close to both of us. And we've been working in this field. And I'm so happy that we could finally do it. Thank you so much. And I'm sure many, many people benefited because for me, when it comes to not just surgery, anything to do with medicine, it is just you, my
Thank
first
you.
go-to person. And your clarity is amazing, not because you're my sister, because I know you are so thorough with everything. So I'm so
Thank
glad that we have been able to give everybody the benefit of that. Thank you so
thank you very
much. God
much.
bless you. And I hope everybody gained something. And do please share your feedback. Okay. And if
Is
you
there
would like to,
any
yeah, any
pending questions?
questions? Yeah, please. And somebody wanted to know, I think we only have about a couple of minutes or maybe not even a minute, but anything to do with fertility treatment, is there any relationship between that and breast cancer?
A lot of people talk about hormonal treatment and breast cancer. There's no such evidence, but I think it is but simple logic. If somebody has been trying too many fertility, the amount of estrogen that body has been exposed to, but there's no actually association that has been reported. I don't know whether it's because of underreporting, but I do ask my patients if they've said that they've had IVF, how many attempts they've had, and I cannot just say I have seen an association, but that would be wrong of me to say because I haven't really done a proper study in it. Yeah.
Okay. Thank you
Yeah.
very much. Have a
Yeah.
great
Bye
day,
bye.
rest of the day, all of you. Bye bye.
Bye bye.
Thanks for joining, all of you. Bye
Bye
bye.
bye. Bye bye. Bye bye.